Next, I would like to invite Dr. Amitava Mukherjee, who is a consultant neurologist in Fortis Hospital and Kidney Institute. He will speak upon RIRS in different clinical scenarios.
A very good evening, everybody. Pushkar has spoken extensively about how to do RIRS and how you should take special precautions to maintain a good quality of surgery. So you can actually use the scope in certain other situations rather than handling stones. We all come across all these once in a while, not very common ones, but rather interesting conditions where you can use a flexible ureteroscope. So while I'm showing about 3 of them for which I have recordings, there are a few others that I would just mention in passing because we are already quite late. So this gentleman walked into our OPD, Mr. Babar Ali. He had a 3 centimeter kidney stone and in the upper calyx and was aptly advised PCNL by a number of consultants in the city. Somehow he didn't want a puncture and he came to us for a third opinion. We also told him PCNL. He said, no, I don't want a puncture. And so he accepted for a staged RIRS. So we told him it could be 2, it could be even 3 stages if it doesn't go in the first stage. So we put in a stent and come out. So we attempted a primary RIRS and luckily after a rigid ureteroscopy, the medium size access sheath went through. It was a large stone and so we started initial fragmentation at 1.2 joules and 15 hertz and then changed over time. And we found this 0.4 and 60 combination works rather well. But it's a total power is quite high and therefore it makes sense only to do when you have a capacious pelvis and where you would have a continuous good water flow, like the water is going inside and coming out so that it actually drains the heat away. Because it was a large stone. So when we first saw this CT, we said, Babar ne Kohinoor chura liya. Looks just like that, a diamond sitting there in the kidney. And we were out to rob him of his stone. And that's how it looked like on C-arm. And that's how it looked like at the end of the procedure. So while there were a fair bit of fragments, they were all nicely dusted. And we thought that he may not need a second sitting somehow. However, when he comes back to us, we find that he still has a fair bit of fragments sitting there. And we weren't very sure why, because it appeared like we had fragmented it quite well, but then in our upper calyx, we had expected that it would clear better than this. Now, this is what we saw when we went in yesterday for the second sitting. So his infundibulum had become edematous and narrowed. And we realized that this high power laser going on for about 70 minutes of breakage time did cause edema and injury and therefore a little bit of narrowing there with stones getting impacted in the edema of the infundibulum and therefore it blocked the rest of the stones from coming in. But this was soft. It opened up easily with the scope going inside and the stone was fragmented, the rest of the stone was fragmented and washed out. So we keep our fingers crossed about what is going to happen with this infundibulum in the future. So one lesson that we learned is, as Pushkar said, a high power, prolonged time, inadequate water flow. So while we are talking about RIRS replacing PCNL, we got to see a problem that we have created by ourselves by doing a prolonged RIRS. So we'll have to draw a line somewhere ki we'll do it only for this amount of time or not go beyond this amount of power. So that I think would be different for different lasers that I use. And while Pushkar was talking about thulium, it appears that thulium actually generates more energy and the burn injury and scarring and tissue injury is more with a thulium fiber laser than holmium. So if you're using a thulium, we have to be extra careful in terms of time and duration for which we do it. Okay, so the second case, this lady, she's a diabetic and she was being admitted in some hospital repeatedly because of hematuria and fever. She was a diabetic for 12 years with a creatinine of 1.3, 0.9 being normal in a female as per our laboratory. And she's had cystoscopy and clot evacuation because of the amount of hematuria she had in the bladder. And when she presented to us, she was having mild hematuria. This was the third or fourth admission when she came to us. And after about 48 hours, luckily for us, the hematuria stopped, the urine became clear, and we thought that's the right time after antibiotics to go in to evaluate what's happening. So she's had a CT scan done outside, and that didn't show anything other than blood in the lower calyx, pelvis, and in the upper ureter. So there was no mass lesion, and after the clots had cleared, we did a MRI again to make sure that we could, whether there was any soft tissue. That was a non-contrast CT, so we did a MRI again to see whether there could be any suspicious lesion. We actually didn't see anything. There was suggestive of pyelonephritis, and CT did not tell us anything other than the possibility of pyelonephritis. So when we went inside, the first thing in the upper calyx was this large necrotic papilla sitting there. So we tried for some time retrieving the papilla with the basket. So the encircle didn't work. For quite some time we tried holding it with the encircle, and the encircle didn't work, and then finally we changed over to the engage basket, and engage basket worked very well. And after we removed this particular papilla, we went in searching for the others, and we found that in this particular patient, she had only one intact papilla left. About 4 of the papillas had already necrosed and sloughed off, leaving behind a cavity, and there were about 5 necrotic papillary tissues sitting there. So that was basically the reason for her repeated admission. So every time she went home, after one sloughed papilla passed out, one other fellow came down and probably blocked the ureter. So we could use a flexible ureteroscopy in this particular situation when we get referrals from ICU consultants or from nephrologists or for a patient, diabetic patient presenting with multiple recurrent infection and sloughed papilla. Maybe after we would usually put in a stent and allow the patient to stabilize. But what we usually do is at the end of the procedure, once the treatment is done, after 3 weeks, we just remove the stent. So these kind of patients give us an idea that maybe when we are removing the stent, when the sepsis is controlled, it might make sense to actually go in and look with a flexible ureteroscope. We might find a few more dead papilla sitting there. And removing that will avoid the complications of recurrent papillary necrosis obstructing the ureter and causing sepsis for the patient. So we tried with this and it didn't work, and I think we'll just go forward, and we were finally able to hold it with the engage. So the engage helped us in retrieving the papilla, and we managed to get about 4 or 5 fairly big size papilla out from this patient. Okay, so the third case, Pushkar talked about calyceal diverticulum with stones in them. So we're talking about now diverticulum-like structure without stones in it. This particular patient presented with flank pain for 6 months. This is one of my older videos about 10-12 years back, so I don't have too much of details. I had a very short video available for me. So this patient had a USG which showed a large cystic structure. He came, there was a IVU which showed an image like this, a hugely dilated thing with contrast, and a cut-off calyx somewhere in the middle calyx or in the upper calyx. So when we had gone it with a flexible ureteroscopy, we actually couldn't see a thing. We couldn't see any opening, nothing. So at that point of time, we took the USG from our lithotripsy room, and under USG guidance, we injected contrast plus methylene blue combination into the cyst. And after that, the surge began, and then we could see the methylene blue leaking out from there, a nice wisp of methylene blue from an opening which was so small, covered with a flap that otherwise that could have easily been missed. And so we managed to put a wire in through that, dilate it, and subsequently that was incised with a laser. So that's routine cutting it with a laser. Pushka has already shown that. So there was no stone. The patient was having pain because obstructed infundibulum. So that's it. I've got these 3 recordings. I just thought I'll mention a fourth. Is that sometimes during a PCNL we might have secondary stones or a stone in a calyx which is not directly accessible with a rigid scope. So you want to go in, you would try to use a flexible scope, a flexible nephroscope or a flexible ureteroscope. The problem with flexible nephroscope is that unless you have a very capacious pelvis, you are usually not able to flex the flexible cystonephroscope in the pelvis to help you retrieve a stone. So if you use a small access sheath or one of the coaxial metal dilators through the amplats and guide your flexible ureteroscope through that, you could find that you could avoid a puncture or 2 and actually retrieve a few small stones from the calyces. So why I'm saying that you would like to have an access sheath is that if the whole scope is actually flabby and unsupported, it makes it very difficult to go inside. Here you're going in through the ureter and therefore you have a good support, and so when the tip is moving, it's all right, easy for you to manipulate. But if you don't control the shaft, you'll not be able to manipulate inside. So if you use an access sheath through the amplats, or if you're using a coaxial dilator, you put in a coaxial dilator that stiffens it and allows manipulation. So I've used it in a few cases, and I've found that using it in that way is helpful. Thank you.
As there is 1 minute time for copying Namankur business, I want to say something. The Bengali Society now do every month their theme-based program. আজকে আমার কাছে অনেকেই ফোন করেছে অল ইন্ডিয়া লেভেল থেকে যে তোমাদের প্রোগ্রাম ভালো হচ্ছে, তোমাদের প্রোগ্রাম আমরা দেখতে চাই। তো আমরা অনলাইন প্রোগ্রাম করতে পারছি না, কিন্তু একটা কথাই বলে দিতে চাই যে আমি যখন 10 বছর আগে বিভিন্ন জায়গায় যেতাম, সব জায়গায় ঘুরে বেড়াতাম, তখন অনেকেই বলতো তোমাদের বেঙ্গলে কী প্রোগ্রাম হচ্ছে, আমরা তোমাদের বেঙ্গল থেকে কেন প্রেজেন্টেশন হচ্ছে না। আজকে কিন্তু সিচুয়েশন বদলে গেছে। তো আই রিকোয়েস্ট অল অফ ইউ যারা আছে এখানে, তো প্লিজ ডকুমেন্ট ইউর প্রেজেন্টেশন, প্লিজ প্রেজেন্ট ইট ইন অল দ্য লেভেলস। যেখানে পারছি প্রেজেন্ট করো, তো প্লিজ ডকুমেন্ট অল। অমিতাভ দা আজকে প্রেজেন্ট করেছে, আমার খুব ভালো লাগছে, কারণ অমিতাভ দাকে বহুদিন ধরে জানি আমি। উনি বহুদিন আগে থেকে RIRS করেন, তোমরা হয়তো অনেকেই জানো না কবে থেকে উনি RIRS করছেন, কিন্তু অমিতাভ দা রেকর্ড করছেন না, প্রেজেন্ট করছেন না। আমি অমিতাভ বলছি, অমিতাভ দা এটা করতেই হবে তোমাকে, আমি তোমাকে ছাড়বো না করলে। তাই প্রত্যেকেই বলছি, পুষ্কর, শশাঙ্ক সবাই আছে এখানে, তোমরা প্রত্যেকেই ডকুমেন্ট করো তোমাদের প্রেজেন্টেশনটা, আর প্রেজেন্ট করো। এই ফোরামে হচ্ছে বেস্ট ফোরাম, বাস ইজ দ্য বেস্ট ফোরাম। আই উইল, প্লিজ write to me, please communicate with me, we will give you a platform to present. Then you will present the bigger platform also. Okay. Namankur, please.